Welcome to AETCM, the emergency medicine channel. So hope you all are aware about the last video, that is our physical examination techniques. So today's video I want to track you from the physical examination techniques to the next part, assessment part, that is our rapid full body scan. So before getting into the demonstration part, I want to give a small brief out regarding the rapid full body scan. What is this actually, and then why they developed this concept in the pre-hospital region or pre-hospital setup. Before that, what is meant by rapid full body scan? So other name for the rapid full body scan, rapid full body sweep. So this is what it is. What we are going to do means, it is nothing but we are going to assess the whole body, or from top to bottom we are going to assess with a 60 to 90 minutes of interval. Okay, so within a 1 or 1.5 minute we are going to do the whole body assessment, that is called rapid full body scan. So suddenly if I am telling in this way, so you can imagine how it is possible. So last video if you watched it means, so we told all the techniques. So in every system how we have to do, what are the abnormalities we will find in the inspection, palpation, percussion and auscultation. So the question will arise in your mind, how it is possible within 1 to 1.5 minutes, how we can cover the whole system. So in this mainly rapid full body scan, we are going to do the only two techniques only we are going to do. First one, inspection. So we know it is a sense of a sight, and then we are going to do the palpation. So it's a sense of touch. So inspection and then palpation. These two techniques only we are going to do in the all over the body. Mean the same time, auscultation, if it is permitted, if it is you are okay with auscultation, means you are going to auscultate only the lung field. So these are the two techniques only, inspection and then palpation. Auscultation is a something add-on one. If you are familiar and then if you are okay with that, means if it is indicated means you can go with an auscultation. Okay. So what I am going to do in an inspection means, just we are going to check the inspection of either opened or closed injury is there or not. Only for the wound. Either it's a open injury or closed injury, or wound is absent. Okay. So wound is there means whether it is a open or closed wound. Injury is not there means wound is not there means negative. That's all. So in all over the body. So wound is open injury means what? So it is an example, then I can tell laceration, abrasions, so puncture wound. So all the things will come under your open wounds, open wound or open injury. So closed wound in the sense burns, contusions, any deformities, so swelling, so all the things will come under the closed injuries. So this is what the thing I am going to do the inspection for. So just to take the head, check for the any wound is there or not. If wound is there means whether that is an open injury or closed injury. That's all. Then we are moving on to the next technique, that is your palpation. So palpation I am not going to elaborate in theory part, so I am not going to explain here. So while doing an assessment part you will understand, so which are the areas, what are the palpatory things, what are the palpatory abnormalities we will find out. Okay. So next, moving on to the next part, auscultation, as like I told, only if it is indicated we are going to do in the lung field alone. Okay, we are not going to auscultate all heart sound and then bowel sound, only we are going to focus on the lung sounds, breath sounds. Okay, these are the two techniques only, inspection and then palpation. So this is what the rapid full body scan. The areas how we are going to approach the person means, first we are going to assess the head and the neck, then followed by your chest, followed by your abdomen, followed by your pelvic, finally your extremities. Okay, so head and neck you are going to inspect and then palpate, and then followed by you are going to inspect and then palpate the chest, followed by your abdomen, followed by your pelvic, and then followed by extremities, 4 extremities. So this is what the plane out or draw out for the assessment part. Then why they developed this concept in the pre-hospital region? So if you are, so we are well aware about the one golden statement in our emergency medicine, pre-hospital emergency medicine, that is minimize the scene time. So that is one golden word we have, right? Minimize the scene time. So in this minimize scene time, rapid full body scan is one part of the minimize scene time. Minimize scene time in the sense what? So we should not spend more time on the scene. As soon as possible, with a possible way, we have to do all the assessment quickly, and then we have to load the person, and then we have to take the person into the definitive care as early as possible. That is the terminology indicating the minimize scene time, right? So in this minimize scene time only they developed the rapid full body scan. If in the case of unconscious, so there we can't spend more time on the field. So Whichever case, for example, if we are taking one unconscious patient, so there we have to do quick assessment, and then we have to load the person, we have to find out the cause. It is not very easy to find out the exact cause for the unconscious. So as soon as possible, we have to drop the person in the definitive care. That is the ideal thing. That is why they developed the rapid full body scan. So this is most important thing you have to perform in the scene. So when it will come means, so first you will reach out the scene, and then you will do the scene safety, everything you will check. Followed by you will assess the mental status. Followed by we are going to do the rapid full body scan. Then you can take the person into your ambulance crew. Then there you are perform all your primary survey and then secondary assessment if time permits. So this is what the flow chart for how we have to act in the emergency situation. So don't confuse with the rapid full body scan to the primary survey. So primary survey in the sense, you know, that airway, breathing, circulation, disability, exposure. There we will do assessment, mean the same time intervention also. But in your rapid full body scan, it is only the assessment part. One thing we can include here, that is cervical spine immobilization. So we will do all the assessment, and then we will apply the cervical collar. So this is the only one intervention we are doing here. Remaining all things only we are going to assess. But in the primary survey, we will do the assessment. Simultaneously, we will manage each thing. So airway patency is not there means we will place some basic airways or manuals, or we will go with some definitive airway management. So don't confuse with that. Rapid full body scan to the primary survey. So we'll get into the demonstration part. We'll meet you there. So getting into the assessment part, first and then foremost important step in the assessment is a spinal immobilization. So imagine if you are going to handle a trauma related cases means, so the spinal immobilization technique is the first and foremost important thing. Spinal in the sense, not alone the cervical spine, you have to immobilize or you have to restrict the movement of the whole spine. So I am talking about the thoracic and then most importantly lumbar spine also. So most of the people we used to imagine like a spine in the sense cervical spine itself, but cervical spine you are restricting by the application of some cervical spine collar. Mean the same time you have to restrict the movement of other spines like lumbar spine. How we are restricting means, so you are doing the log rolling. So by the way we are restricting the motions. So now we'll get into the assessment part. First you have to ask your co-resuscitator person to restrict the cervical spine movement. Okay, so how we are going to restrict? Just we are going to place your hand over the ears, thereby you can restrict the movements for first step. Then you have to apply the cervical collar. Before that, how I am going to approach the assessment means, first thing we are going to assess the head and the neck, followed by chest and abdomen, followed by your extremities. So if you are gone through or if you are remembering our pre-hospital assessment list, so we are going to simplify means A, B and then C. A in the sense that is airway, I am indicating the area of your head and then neck. B in the sense that is breathing part, that is your chest. C in the sense that is circulation, I am indicating your abdomen, pelvic including your extremities. So this is the way you can channelize the A, B and then C. Now first thing A part, what I am going to do means, so as like I told, we are going to concentrate only inspection and then palpation technique. So in head part you are going to inspect, so that your hairs will cover the scalp area, right? So you are going to inspect and then palpate the scalp. So inspect, just to place your hand like this and then make an impression, just to see if you are seeing any visible blood tinges or blood stains are there or not. So you have to tone your gloves and then you have to do the just gentle impression over the scalp area, and then simultaneously you have to see your hand. Then second, go beyond and then take your hand like this. Then after like that you have to do the all your regions of your anterior region of your head, scalp area. So that is what your head. Okay, then followed by you are going to the neck region. Neck, what are the areas we are going to concentrate means, here also first to do the inspection if any visible like open or closed injury is there or not. Then followed by we are going to see the vascular related things. Vascular, what I can see here, you can, if the person in a supine position, we can't do anything. Like if the person in semi-fowlers or fowlers means, you can see the jugular venous distension. That is the one thing. Second thing, you can see the midline, the tracheal deviation. If the trachea is not in a midline means you can't palpate. So how you can see the tracheal deviation? Just to place your finger over this sternal notch area. So if the trachea in center means you can able to palpate the trachea. If it is not center, deviated to some other side means you unable to palpate this trachea. This is the second thing. Third thing, we are going to see the just ask the person regarding the tenderness of posterior side, your midline cervical spine. You have to ask the person related with an tenderness. So this is what the thing we are going to see in your neck. So neck, first thing, vascular wise jugular venous is distension if the person in your semi-Fowler's or Fowler's position. Second thing, you are going to check the tracheal deviation. Third thing, posterior tenderness, midline tenderness or cervical spine tenderness. Then one more important thing, if the person have a laryngeal fractures means you can palpate and see the crepitations. So that is also one sign you can note in the neck region. So after that, if it is a trauma case, we are going to apply the cervical collar. This is one of the most important thing we have to do in scene and then at the site of incident itself. So in cervical collar, it is very easiest to procedure, but we can't give a least important to that one because it's one of the life-saving procedure. So cervical spine collar, we have a 3 types of collar we have. First thing, here I have something called soft collar. So never ever at whatever circumstance don't use this soft collar because it won't restrict the movement. It just for some other conditions, some other medical conditions. Okay, it's not for specially made for your cervical spine restriction. Okay, that's a one collar, soft collar. And then one more thing here I have, there is a Philadelphia collar. This is what most of our ambulance crew, we have this Philadelphia collar. This one you can use, or else nowadays we have something called universal collar. So it will be like these are the things are fixed positions, like you have to choose either small or large condition, but here you can adjust this collar. So you can just release this portion and then based on the size you can adjust this collar. So that is the advantage of this collar. So 3 types, first one your soft collar and then Philadelphia, and then as like I told, so you can adjust this collar. This is a universal collar. Okay, so these are the 3 colors. Recommended one is either you have to use the Philadelphia collar or you have to use this universal collar. Okay, so how we are going to measure the size of the collar means it is very easy. Just to place your fingers between the angle of mandible to the shoulder. So here you can see like this. Okay, so between the angle of mandible to your shoulder, so if you are placing your hand like this means you will get approximation, that width you will get. So that width you have to measure here. So the width you have to measure here. So between this area you have to measure. If it is going lengthier means you just release this lock and then extend the area. So you can extend like this. Okay, so now the size is only 4 fingers. So I am going to reduce this one. So 4 finger width. Okay, so first thing regarding cervical spine immobilization, positioning, placing the hand over the ears is the first step. Second step, selection of the collar is most important thing, Philadelphia and then universal collar. Third thing is your size measurement, collar size measurement, that is you have to use the finger, you have to place your finger between the angle of mandible to the shoulder. Okay, then final important thing, how we have to apply the collar. So it is very easy again, you just wrap the collar posterior side and then place this anterior portion and then place the velcro straps, that's all. So make sure the person's head in the neutral position. His eyes have to place means towards the roof of the hall or roof of the things. Okay, then you are going to wrap the collar posterior side. Then place the anterior portion of your collar. And make a strap. Okay, so this is the way you have to place the collar. So it should be in a correct size. You should not over measure or under measure. Anything will cause the next problem, another problem it will cause. So this is the way you are going to do the A part, so head and the neck. Followed by we are going for B, that is breathing part. Here the breathing we mentioned as a chest. So chest, what are the things we are going to do? So the same thing like open or closed injury, mainly sucking chest wound like open pneumothorax you have to check, and then followed by here also we have some bony means ribs we have. So ideally you have to check for the integrity of the ribs. So whether the continuity of the ribs quickly you have to assess. Followed by you can check your things like crepitation. So if the bone fracture is the rib fracture is there means you can see the crepitations. So these are the things you have to check in your like paratoxical movement, all the things you have to check in the chest. So the area we are going to check paratoxical movement, crepitations, and then you are going to check the continuity of the bone. So this is what your chest. Then followed by your abdomen and then pelvic girdle. So abdomen, here also first thing you have to do the inspection. Inspection wise you have to check the open or closed injuries. Second thing you have to check the abdomen distension. So in the case of bowel obstruction or in the bowel injury means there you can see the abdomen distension. So that is the second thing. Third one, you have to check the rigidity of the abdomen. How you can check? Just to place your hand and then press over the 4 quadrant region. So ask the person if any tenderness or rigidity you are finding. So just gently palpate and then ask the person regarding the pain or tenderness. Okay, so 4 quadrant you are going to, we are not going for the all 9 regions, so we are only focusing on the all 4 quadrants alone. Okay, right upper, left upper, right lower, and then left lower. So this is what your abdomen. So followed by your pelvic girdle. Pelvic girdle wise, check for the here also open or closed injuries. So here what we are going to expect means whether any pelvic injury is there or not. How you can identify whether the person have a pelvic injury? So first thing you can see some ecchymosis or discoloration over the pelvic region or ilium region. That is the first thing. Second thing, you can see if in the case of male you can see the scrotal swelling. That is the second thing. Third thing, you can see some if any pelvic injury is there means you can see some blood tinging over the your meatus, urethral meatus. So those are the 3 signs will give you the idea regarding the pelvic injuries. Okay, if anything is there means straight away we are going for the next step of management, that is pelvic binder application. Okay, so this is what the pelvic. In pelvic area, if the person doesn't have any pain or tenderness means you can do the pelvic compression test. Remember, if the person have a pain means you have to think about the next step of management, but if person doesn't have any complaints means then you can do the pelvic compression test, that is to identify the pelvic instability. How we have to do means, so you have to place your hand like this, so you have to compress inward and then downward and then inward. So downward and then inward. So here you can ask the person the feeling of any pain or tenderness or any you are feeling any instability. So we know already, so we are pelvic fractures, there are 3 types are there. So first one, anterior compression, lateral compression, and then you have something called vertical shear fracture. So where the pelvic compression test will be positive means if the person have an open book fracture like anterior compression fracture means there the pelvic compression test will be positive. And then one more thing, if you want to apply a pelvic binder, there where we have to apply the pelvic binder only in the, it will work out in the your open book fracture. So it won't work out in your vertical shear or lateral compression fracture. So these are the some ideas you have to keep in mind while doing a pelvic binder application. So then moving on to the next area, that is your extremities. Extremities, what you can do means, so here also there are 4 areas we are going to do the PMS. P in the sense pulse, M in the sense motor activity, S in the sense sensory. So pulse, only we are going to coordinate or we are going to assess the distal pulses. So in upper extremity, distal pulse your radial. Okay, same area, both side you have to assess. Simultaneously you have to palpate the both upper limb pulses, and then you have to make sure for the rate, rhythm, regularity, everything you have to check. Then lower limb wise, which one is your distal pulse? You can check the dorsalis pedis and then posterior tibialis. So this is what your pulse related. Motor activity wise, you can ask the person to thumbs up, or you can ask the person to move their toes, that is motor activity. Sensory also, you can scratch over that your dorsum of the hand and then dorsum of the foot. You can ask the person, you can assess the sensory. So we are not going to assess all over the area, only the distal pulse. distal area motor sensitivity, and this only we are focusing on the distal area because we don't have a time to assess each and everything. So this is what regarding your extremity. So we started from the A, that is head and neck, B, that is breathing part, circulation, that is abdomen and then pelvic cavity, and then finally extremities. Now we will see how to apply the pelvic binder. Pelvic binder application wise, we told, right, it will work out only in the posterior compression fracture, or it is work out only in the open book fracture. Okay, so how to apply means, so it is very easy, and then you have to apply at the level of greater trochanter of the femur. So commercially we have a lot of devices like pelvic binder, and then some other straps also we have in our ambulance crew. If you don't have anything means, you can use your bed sheets also. So how to apply means, just so make sure you are wrapping the bed sheet. Okay, so you have to place it at the level of greater trochanter, I told, right? So just drag it to the upper region. So drag it. You should not immobilize slot. Okay, mobilize slot. You have to slowly drag it, and then so this is the level of greater trochanter. Okay, so greater trochanter. Here we are going to tie our pelvic binder. So just wrap, take it out. So this is the greater trochanter level. So I am going to tie, and then one more knot and tie it in the. So if you have a sponge holder means you can apply, or if you have any tag means that's also you can apply, or else if you don't have anything means you can apply this way also. So this is the way we have to do the pelvic binder application. So still now we did the anterior portion of assessment, and then we applied the pelvic binder. Actually in the rapid full body scan, we don't have a pelvic binder application in this assessment part. For an extra given to give an idea, we applied this one. Okay, rapid full body scan, it won't come as a separate part. We are going to do the assessment, and then finally we are going to doing the log roll, and then we'll shift to the spine board, and then we'll shift to the ambulance screw. That is what the things we are going to carry on. So next, move on to the posterior part. If you have a scoop stretcher means, we don't want to do the log rolling, all the things. Just we are placing the scoop stretcher, and then we are going to shift the person to the area. But if you don't have a scoop stretcher means, ideally you have to shift in the spine board, and then only you have to move to the person from the area to the crew. So how we have to do the log rolling means, again one person's hand should be placed on the shoulder, and then one hand over the pelvic area, and then you have to ask your co-resuscitator on one hand over the pelvic and then one hand over the knee region. Then we are going to shift. So while doing a log rolling, so we should not it should be coordinated movement. Okay, so how we are going to do means, first place your one hand over the shoulder, one hand over the pelvic area, and then one another co-resuscitator person hand over the pelvic, and then one over the knee. So you are going to coordinately move. Yes. So here I have one more co-resuscitator carrying the spinal board. So one person have to give a command like 1, 2, 3, and then we have to move, and then we have to do the posterior assessment and then spine board shifting. So how we are going to do means 1, 2, 3. So this is what we are expecting. Okay, it should be a smooth and then coordinated movement. So that's why one person have to give a command like 1, 2, 3, and then I have to do the posterior assessment. So that lower thoracic area and then lumbar regions. Here also the same thing, like you have to inspect and then you have to palpate the spinal area. You can ask for any tenderness. Then again we are going to re-rotate the person the same way, 1, 2, and then 3. So place the person hand over the regions and then shift him into the mid position. So here, so still now you can see here I have the person with the, even though we apply the cervical spine application collar, still the person is holding the spine. So this is the way we are restricting the spine movement. So we are not going to completely immobilize. This is called C-spine restriction. We are restricting the movement of spine. So that is why still the person is continuing the her position. When she have to relieve means once you apply the cervical spine and then spinal board, there we will apply something called head blocks. So here you have to apply some head blocks, then only the person have to remove the hand. So until that the person have to place, or until that she have to maintain that position. So this is what the C-spine and the posterior assessment and then log rolling. Now we are going to shift the person. So everything, whatever steps we are making in this area, that should be like a coordinator movement. So here you can see each person's spine, it should be like a straight spine. So while doing an assessment or while doing a cervical spine immobilization to carrying the person also, your spine should be straight line, okay? You should not harm yourself also. That's also we have to keep in mind. So before shifting, you have to check the apply the velcro straps everywhere, the persons wherever you have a provision. So you have to apply the provisions, and then you are going to shift with the coordinator movement. So 1, 2, 3.